what can we do to prevent or to optimize that? And I'm sure he has a lot of data on that preoperative impact. So let's hear what he can learn us, but at least interrupt and make a discussion on it.
Okay, thank you very much for the introduction. I walk around a lot, so please bear with me and I ask questions. This talk is really going to be about the high-risk obese patient. And we've swapped the first two talks around. Mine is much more general. Professor Pelosi is going to be a little bit more specific about ventilation. I'm going to talk a little bit about why bariatric surgical patients die, all of that. And it's primarily about identifying the high-risk patient and working out what factors we can change to improve risk. Okay, and talk a little bit about the UK experience of the multidisciplinary team, the MDT, which you'll hear about again and again. And I'll talk about the changes that have occurred since we introduced that. Some music on here. Oh, okay. Okay, I'll talk loudly. I'll talk loudly. Okay. There have been lots and lots of papers talking about mortality in bariatrics. I'm sure these meetings go again and again talking about it. But when you put those papers together and you look at the changes over the years, over the last 10, 15 years, you look at the mortality of various procedures. The reported mortality of gastric banding, as you know, is very low. Basically, 0%, it's tiny. When you look at the studies looking at gastric bypass, it gets a little higher, and most of these older studies tend to show around about a 0.5% mortality. There are a couple of outliers that showed higher mortality figures. And then you had things like the bypass procedures, the pancreatic bypasses, and they had an even higher mortality because you're doing more complex anastomotic surgery. And sometimes it's not just the surgery, it's clearly the patients as well. But these were the sort of mortality figures that used to quote for a band, for a bypass, and for BPT procedures. The UK has got the National Bariatric Surgical Registry. Some of you will have seen data. This was published a few years ago, and from the UK, when they looked at all the figures, over 7,000 procedures, overall the mortality was reckoned to be somewhere between sort of 0.1 and 0.3%. But this is in-hospital mortality, and at that point, it was all related to bypasses. The new set of figures that came out yesterday, I got these from the UK, that says the word draft written across it, shows a change. The mortality overall has gone down slightly. This is in-hospital mortality. The slightly worrying thing is the most dangerous procedure in the UK in the last 3 years has not been the bypass in gastrectomy. Interesting question. This data is going to come out shortly. But remember that a lot of these deaths don't occur in hospital. This is in-hospital mortality, and the issue is that most of them die afterwards. It's not the procedure though, it's the patient. We know that. When you look at the factors in patients, I jumped ahead, when you look at the factors in patients associated with mortality, it's the older patient, it's male gender, and it's protective if you're privately insured. And I think these figures, although they're moderately old, are probably things that we will accept today as being genuine. So, is it the age per se, or are these markers for something else? That's the question. And when you dug into this paper a little bit more, you've found that heart failure was associated with roughly a 10-fold increased mortality risk. Renal failure, the same, a 10-fold increased mortality risk. These two often go hand in hand. But the need for reoperation is associated with a 20-fold increased mortality risk. So we'll come back to that. Cardiac disease is far away the biggest killer. The problem about it, or the thing about it, is that cardiac disease is a marker of a poor physiological reserve. And it's not the first operation that kills you, it's the reoperation. Patients with poor physiological reserve just don't do well if they need to have a reoperation. So what we kind of need to do is work out which patients are at high risk and try to avoid them getting complications. There's a whole host of cardiac factors that are associated with ischemic heart disease per se, heart failure, possibly sleep apnea related, we'll hear about that. This vague concept of obesity cardiomyopathy, which is not quite clear, and hypertension. And of those, far away the largest is this one. It's the presence of heart failure causes problems. And heart failure is common in the obese patients. If you look at obese populations over time, the incidences of heart failure get up into the sort of 10 to 15 to 20% range over time. So there's a lot of patients out there with poor hearts who are morbidly obese, and it's patients who've had many, many years of obesity. So it's the older patients who have bad hearts, telling you something you don't know. The question here is not just the heart though, it's about the whole body. It's about the whole body's ability to improve and respond when they need to increase cardiac output to survive the complications when the surgery goes wrong. Okay? And the way that the people have been looking at this in the vascular and in the colorectal, much older age groups, they've done this thing called cardiopulmonary exercise testing, which many of you are familiar with. It does require a degree of enthusiasm. It's very labour intensive. It takes a couple of hours to do a test and interpret it properly. And the concept behind this is that you're looking at their ability to increase their cardiac output. You're looking at their cardiac reserve. And there's this concept of the metabolic equivalence. This is something from the European Cardiology Society. And one metabolic equivalent means you can just about survive. To be able to walk around at decent distances, you need about 4 metabolic equivalents, and to do more robust exercise, to participate in sports, you have to be up to 10 metabolic equivalents. So this is quite a nice little scale. To think about patients, any patient that you see as a surgeon who can do this stuff, they're probably young, reasonably healthy. If they have a complication, I'm an intensivist, I can fix those patients. I can support those patients whilst you fix them. They're not likely to go spiralling down. The patients who are here, who can only just do this, walk around inside the house, can hardly walk distances, they're the ones who, when they end up on the ITU and they need that reserve and that response, they won't do well. So this is how you do CPET testing, but not many of our patients look like this. And when you do it in the morbidly obese, there are real technical problems. And this is probably one of the reasons it doesn't work very well. There are difficulties with the machines, there are difficulties with the limits of the patients. Very few patients complete the protocol. And although there are 1 or 2 people, this is a classically quoted study, saying that it does have a role and it does delineate between patients. In this study, although they were bypass patients, reasonable size, reasonable age, they only had 8 events as their composite endpoint in 109 patients, and the power of that study is rubbish. So, and there's a bit of a mishmash in here. I can't really see a clear picture. There's a bit of it. How predictive is it? It's not, really. And larger studies subsequently done. This is a very good study that was done by a very good group from York in the UK who are very keen on CPX testing and have done a lot of it. And they looked at over nearly 400 patients who they tested, and then 250 of those went on to have bypasses. And there was a fair number here of complications and readmissions, but they found CPX testing was not helpful. They found this was a much, much better predictor. So the OSMRS, which you're all familiar with, it's been around for 10 years now, getting on for, looked at these 5 factors. And if you had any of these 5 factors, you scored a point, and depending on the number of points, they predicted a risk. But when this study was done, they were looking at, I think, if I remember, I wrote the numbers down here, 33 deaths in 4,400 patients. Now that's a 7-fold higher incidence of mortality than the figures I quoted you at the beginning. So that's curious, and you wonder just how applicable and how representative that is. In fairness, these patients were all having gastric bypass, and the vast majority of these were open gastric bypasses. It's been looked at in a couple of subsequent studies, and these guys, Canadian group, showed that BMI, gender, and to a lesser degree age certainly are predictive of complications, but they didn't find that hypertension and thrombosis were that strong. So a slight pinch of salt with the OSMRS, but we do buy it. We do believe it's probably not far off the mark. Diabetes is a very interesting one and probably should be somewhere in the mix as well. What we use as an anaesthetist clearly is the ASA status, and we're all familiar with these 4 grades, 1, 2, 3, and 4. Most of our patients fall within the 2 to 3 range. There is an ASA 5 and an ASA 6. If you take a patient who for organ donation, they're an ASA 6. The intriguing thing is that this group here, the ASA 3, really does cover a multitude of sins, and there's a lot of patients in there who could be very, very bad, and there are some patients who are not that bad at all. So in our institution, we use an ASA 3+. Just like in laryngoscopy, we've gone from a grade 2 to a grade 2A and 2B. Here, I think there's a future for the ASA grade 3 being subdivided. And when we looked at our institution and looked back at our database of now about 3,300 patients, we don't have ASA grades on all of them, unfortunately, so there's probably quite a few missing ASA, but the high-risk patients we've certainly got the data on. We've had 4 deaths in the ASA 3 group, but when you look at the 3.5s and the 4s, the much smaller numbers, the mortality rates are significantly higher. And I'd suggest that the ASA, if it's applied properly, is probably as applicable as the OSMRS. This is all comers, this is males and females. What do you think happens when we look at males? Dramatically higher. The numbers are much, much smaller. The deaths are all in the male groups. And here you go. If you have an ASA 4 male having, or a high ASA 3 or an ASA 4 or 3+, you're talking about mortalities of 5 to 10%. And we quote this figure to our patients. And we quote this figure to our surgeons, so they can decide what to do. The question here is, what are the modifiable factors? And that really what this talk was aimed at. Well, there's nothing we can do about that or that. You can do a little bit about thrombotic tendency, and that's what we talked about very well by Luke at the end, I'm sure. A little bit about hypertension, but really the one thing you probably can adjust is to try and do something about BMI. Now, clearly clearly these are risk factors. Whether adjusting them really makes a difference is another question. But we generally feel that they probably do. If however, it's felt that the risks, a 10% risk, outweighs the benefit in the patient, then maybe we shouldn't be going ahead and doing surgery unless we can reduce that risk. And the question is whether strict diet or balloons and giving patients real targets are going to be useful in allowing you to make your final judgment call. And I consider a concept here, which I think you're all probably subconsciously aware of, which is that your risk of death goes up as you put on weight. You know, and the higher your weight, the greater your risk of peritoneal mortality. And the theory goes that if you actually reduce your diet, or go on a diet, reduce your weight, you'll bring yourself down substantially. Now, this isn't true necessarily for all patients, because what's the most important thing when you're looking at a patient? He's obese. What's the single factor that worries me when I look at an obese patient? It's where's the fat? Yeah? So if you've got someone who's a real sort of pear shape, and it's all around the edges, then losing the fat from the edges periphery probably doesn't affect their mortality very much. But if they've got that centripetal fat distribution, that classically male fat deposition in the abdomen, to lose the weight from there, firstly, it may have metabolic effects because that's the most toxic fat, but secondly, it makes the risk of surgical complications, I think, significantly lower. If the surgeon has a good view because there's not a huge liver and they're not hitting it, it's very, very likely that the complication rate is going to go down and that will translate into a better outcome. So it seems entirely appropriate that we should try to reduce that excess weight. The question is how we do it. And it basically comes down to balloons or diets. Well, balloons are not without risks. They don't always work. This is a paper that's just coming out, I think, this month in obesity surgery. I know it's not last year's one. There's another one coming out this month. Patients feel wretched. Lots of complications. One of the most stressful anesthetics I've ever had in my life was trying to retrieve a balloon from a very high-risk patient who was considered too unfit to have surgery, but they decided to give him a balloon. He came back about 3 weeks later, he'd been vomiting, he'd not lost any weight, he was ketotic, he was throwing up the whole time. It was the most stressful anesthetic. His ST segments and my ST segments probably went up and down in parallel. He did survive and went on to have an operation later. But taking these balloons out, if they cause complications, is a nightmare. But if the patient does lose weight on a balloon, it is a good marker of how they're going to do after the procedure. Supervised diets. Now I know that some of the Belgian centres are very, very keen on these, and we've gone away from balloons a lot, and supervised diets do really seem to work. But you have to give patients very clear targets, a lot of supervision, a lot of reinforcement that they're doing well, and you have to see them in the clinic every 2 weeks to say, yes, you're on target, yes, you hit the magic 20 kilogram or 15 kilograms, we'll get your surgery, we're going ahead now, provided you don't put the weight back on. However, there is no evidence, and believe me, I've looked hard in the last week or two, trying to find a study that demonstrates a significant benefit in terms of outcome, but it's just not out there. And again, just looking at the gastric balloon again, this is that same slide from our UK National Bariatric Surgical Registry. Of all the procedures done in the period of 2011 to 2013, only 1% of procedures were insertion of gastric balloon. It says something about the way that the UK is sort of thinking. So, how do we identify what is modifiable? How do we make changes that we need to make to try to improve and reduce risks and improve outcomes? You need a lot of brains put together. And in the UK, this is the final bit of my talk, we talk about the multidisciplinary team and the MDT, the multidisciplinary team meeting. And the MDT has been around in some form for quite a few years in the UK, but the UK National Institute for Clinical Excellence, NICE, came out and made a comment, and it was in conjunction with this group, the Royal College of Physicians, that all MDTs, that all bariatric surgical services should have a multidisciplinary team meeting to oversee patients who are basically going for surgery, severe and complex obesity issues. And they then come to say who it should include. Okay, so who does the MDT include? Well, fairly obviously, the first person who have to have an MDT is your surgeon. Okay. And obviously you need your anaesthetist, and a dietitian, and you may or may not want the help of a sleep physician. They're quite useful for some patients. I'll tell you the numbers that we send off to sleep physicians. You obviously need a special nurse. You may want a psychologist to come and assist you. And we have a psychologist at all our MDTs. And the psychologist in our institution, in our unit, spends twice as long with the patient as anybody else. And a lot of our problems with failure are patients who aren't right for the surgery. They're just not right. They're not going to do well. And then lastly, of course, we have the bariatric physician. Okay. And the role of the MDT is very clearly, it's for the whole group to identify who will benefit from surgery and who won't, identify who needs optimisation and who can be optimisation, and probably one of the most important bits, to allow this guy to say no to a patient with the backing of specialist colleagues. Because if you turn patients down, and all the surgeons in this room know that if you turn patients down, you know, it's often the grief, the accusations you'll get levelled at you is not there. But in the NHS, it's very, very important that we do, when it is inappropriate, turn down patients. In our institution, how it works, we have a one-day, one-stop service. And on that Friday morning, the patient sees all these people together. All of them review the patient. The surgeon gets out of bed around about midday. No, he doesn't. They then join up in the middle of the day, and the surgeon comes in. We just have a meeting in a room together. There's 6 or 7 of us sitting around, and we talk through every single patient one by one. So the physician will say what they think, the dietitian how they'll do with their diet, the nurse may get some input, the psychologist whether they're appropriate or not, the anaesthetist what the risk is. And in the afternoon, the patient gets together with the surgeon, having pretty much decided at lunchtime what we're going to do, who's going to get off and what, and discusses A, what the best procedure is. A lot of our patients think they're going to have gastric barriers, they get told we're probably better off with bypass or a sleeve, and then tell the patient they're not going to go ahead. Does it work? Well, this is our experience from Chichester. Halfway through this 4-year period, the NICE guidelines were forced upon us. We had to follow those guidelines and have the MDT. So it changed halfway through this period. So this is our practice. Before we had got to this stage, before the first of these 4 years, we already had an experience of over 1,000 patients. There's a bit of a learning curve here, but not a lot. And we compared the first 2 years, from the middle of 2008 to September 2010, and then from September 2010 onwards for another 12 months. In this period, there was an anaesthetic review, but it was after the decision had been made for surgery. Here, we have the full meeting before the decision is made to offer surgery or not. Does that matter? Well, all the NHS patients were seen, and of this number of patients reviewed, 141 were referred on. So it's a little over 10% get sent off for further investigations. But the physician, the anaesthetist, most of our patients, we tick the box and we say, yes, you're okay, you go through. But around about 10, 12, 15% there are being either referred on for further investigations, and most of it sleep studies or cardiological input, but a fair number are being advised not to have surgery. And if they see a physician and an anaesthetist in the morning who says, look, this really is high risk, I'm not sure you really want to be doing this, and then they see a surgeon in the afternoon who says, you know, this really is not going to benefit you that great. So we're talking about the 65-year-old ladies who sit on a sofa who burn up 1,000 calories or 1,500 calories a day, who really are, they're not going to benefit from having this done, and they're a high-risk population. That's the sort of patient we're advising against surgery. And quite a few of the ones who get deferred. And the impact, does this help? Does it actually make a difference to patient outcomes? Well, first cohort in the first 2 years, second 2 years, similar sort of numbers, similar BMIs, similar ages, slightly fewer of the ASAs greater than 3. So, as I said, we classify patients as 3.5 and 4. Basically, same group. In the first 2-year period, there were 46 patients out of that 780 were admitted to the critical care unit. And level 2, that's just sort of supportive arterial line, a bit of CPAP maybe, 86 ITU bed days used managing that patient group. And 22 were full-on ventilated, renal failure, falling in a big heap of patients. All but one of those survived to leave the hospital. But it's a spread. That's not 20 days of one patient and one of the others. That's a spread of about 7 or 8 patients. However, after the MDT was introduced, a dramatic fall. I mean, every single one of these p-values is massive. This is going to be presented at the European Society of Anesthesiology meeting. We're getting a sneak preview in Stockholm in the summer. But it is a big, big impact, and we will discuss why that is in a minute. So there you go, that's my talk. In summary, the questions as a surgeon you should be asking is, what is their cardiovascular reserve? And the key question is, will they survive a leak? If you don't think they'll survive a leak, you probably should not be doing the operation. And you certainly want to make sure the best surgeon is doing the operation on the day. Do they have modifiable risk factors? And the ones you're looking for is sleep apnea-related heart failure, poorly controlled blood pressure, or symptomatic heart disease. Okay? As a surgeon, love your anesthesiologist. Communication is everything. Ask the patient, ask for advice regarding risk before promising an operation. If that's the one message I could give everyone today, I really would say that. For that high-risk group, get someone to sift through them. I think your anaesthetist can do that. No evidence to support that. And the final slide, beware the old rabbit. Thank you very much for your attention.
Suppose there's still some questions, but we'll take a little time for that, sure.
I'd like to put the two questions. Is the is a 2 or always a 3?
No, it's not always a 3. We have ASA1 patients